Okay then, so why did we carry out this research in the first place? It was very much in response to the integrated care systems, or ICSs, becoming NHS statutory bodies last year. So we decided to reach out to some of our thought leaders from the NHS who sit on the GKA panel and conduct some depth interviews to understand a little bit more about these new NHS structures. Now, trying to navigate the NHS can be an extremely complicated exercise at the best of times, and we wanted to find out how ICSs are taking shape from a leadership perspective, the impact on the front line from both a practitioner and patient perspective, and then what that means for the wider sector and market research. Now, I spoke with a number of senior leaders from the NHS, including a member of an integrated care board exec team, a former CCG chief exec, a head of medicines management, and also a place lead director, all of whom work for a variety of different ICSs, and some have been operating for years prior to them becoming statutory bodies last year. Now, before I cover the journey to ICSs and the reforms that they aim to achieve, I think it's important to contextualise that these reforms are happening against the backdrop of a service recovering from the impacts of the COVID pandemic on both staff and growing patient waiting lists, staffing shortages across the NHS and social care, and a cost of living crisis. So that said, these reforms should in time ease pressures on the NHS, reduce bed blocking, and ultimately improve the general population's health. Now, our population is very different from when the NHS was first established, with individuals living much longer and experiencing multiple conditions, and this obviously creates greater demands on the NHS. Now, the current government have initiated 2 reform programmes during their administration, which have led to the current position of ICS and the statutory integration of health and social care. Now, this move aims to bring greater connections between all services that have a role in health management, health efficiencies, and general population well-being. A primary function of integrating these services is designed to increase efficiencies, reduce barriers such as bed blocking, and improve outcomes for patients by getting them into settings that are appropriate for them. Now, ICSs build on a number of reform programmes that I'm sure you're all familiar with, including the move from PCTs to CCGs before our current structure of ICSs. Now, these reform programmes aren't discarding lessons learned from previous programmes, but rather each time taking the ambitions to a new level and looking at elements that have emerged from existing programmes. Now, the most recent reform was introduced back in 2019 and built on the government's NHS long-term plan. At its core, ICSs were designed to integrate services across health and social settings and provide greater autonomy at a local level to drive health and well-being across communities. Now, in July 2022, statutory arrangements for the integrated care systems finally came into force. Okay, so let's just explore what an ICS actually is then. So ICSs are essentially partnerships that bring together NHS organisations, social care providers, local authorities and others to take collective responsibility for planning and delivering joined up health and care services. Now, in turn, they aim to improve the lives of people who live and work in their area and reduce inequalities across geographical areas. 42 ICSs have been established across England and are led by an integrated care board and an integrated care partnership. Now, to enable accountability within this structure, ICSs will operate at 3 levels. So firstly, there's the system level, and this will typically cover populations of approximately 1 to 2 million. The second level is place, and this usually covers a population of around about 250 to 500,000. And then finally, we have the neighbourhood level, and this usually covers populations of approximately 30 to 50,000. Now, these 3 levels of operation are designed to look at the whole population and identify healthcare needs and preventative action. So these area levels look at the different needs of populations within a region. So for example, where pockets of deprivation are impacting on health down to neighbourhoods, and where local reflection on healthcare priorities can be identified, actioned and shared. Also operating at these varying levels retains localisation but brings about healthcare efficiencies such as medicines buying at the system level.